I will present you the AFACART trial, at least the preliminary results. First, these are my disclosures. What is the AFACART study? The AFACART study is a European multi-center feasibility non-randomized study using this non-invasive panoramic electrocardiographic approach that has been described by Bordeaux and that you have seen earlier in the morning. Very briefly, because you've seen that before, this is one of the systems that allows to see the drivers during atrial fibrillation. So this is a vest of 252 electrodes. The patient has to undergo a CT with the vest on, which allows to reproduce the anatomy. And then from the electrograms that are recorded, the system will give us the location of the drivers which could be either re-entries or focal breakthrough. This is a typical example of an AF window of 1 second. You see the left atrium and here the roof, the posterior left atrium. You see that there is something organizing here at the ostium of the right vein, some re-entry, and then you see that there are two focal breakthrough, meaning two centrifugal activation from the roof in this window. So actually the main objective of this study was to see first if the results from Bordeaux, which seem to be very interesting, could be reproduced in centers without experience with the system. And so we decided to do this study to evaluate the utility of this system for persistent atrial fibrillation. The secondary objectives were to evaluate the absence of AF recurrence during a follow-up of 12 months after the procedure, and also to evaluate the effectiveness of non-invasive mapping compared to conventional standard of care method for AF mapping and ablation procedure. So we have 8 centers in the study. In Belgium we have 2 centers, mine and the one from Brugge with Professor Matthias Detzkaver. We have 2 centers in France without Bordeaux intentionally with Jean-Paul Albinck and Bruno Koschmez, and 4 centers in Germany with Thomas Rostock, Arenz, Neumann and Isabel Leisenhofer. There was a steering and education committee with myself, Douglas Packer, and Sabine Ernst. Basically, we decided to include all of the patients with persistent atrial fibrillation as defined by the guidelines, with at least 1 week of continuous atrial fibrillation and resistant to at least one antiarrhythmic drug. And the exclusion criteria you can see here were mainly any previous LA ablation, any previous LA or RA surgery, a very enlarged left atrial diameter of more than 5.5 centimeters, presence of any cardiac valve prosthesis, clinically significant valve disease, and NYHA class 3 or 4 congestive heart failure. You've seen the methodology early in the morning, so the patient received the vest and the CT, and then we select windows of at least 1 second of pure atrial electrical activity. That means that we select the windows without any QRS or T wave, to avoid some artifacts from the QRS. And we cumulate all of these windows to have at least 15 seconds of mapping during atrial fibrillation. And then the drivers were defined as local reentrant circuit if there was more than 1.5 rotations, or focal breakthrough if there were more than 2 focal breakthrough through centrifugal activation, as you can see here, appearing in the same spatial location per window. And then at the end of the process, we have this kind of map, which is a cumulative map with all of the drivers recorded during these 15 seconds of atrial fibrillation. And you see that we have this color representing actually the density of the trajectory of all of the rotors that have been recorded during these windows. And you have these points representing the location of the focal breakthrough recorded. And then the ablation strategy for the study was really clear. We really wanted first to target the regions where we had the most of the rotor of the drivers. In this case, you see that it was located in the left veins and in the left appendage, where we had 19 drivers, 12 re-entries and 7 focus. And then in the right atrial appendage with 15 drivers, right vein septum, etc., etc. Of course, we monitored the left atrial and the right atrial cycle lengths throughout the procedure. The local endpoints, we discussed a lot about the local endpoints for the study, and we rely on the results from Bordeaux. So we decided to ablate the region of the trajectory of the rotors, as you can see here. But we really recommend to look at the electrograms and to do exactly the same as what we do for the cafes. That means that we look for an increased local cycle length beyond the appendage cycle length, or to an organization into something which is discrete, like you can see here, as compared to this kind of cafes. So we didn't look for complete eliminations of the electrograms. This is the ablation protocol. The first step consists of the driver ablation, as I showed you just before. If atrial fibrillation terminated during this step, we always completed the driver ablation during sinus rhythm, so something purely anatomical. And for any case also, we complete PV isolation if necessary. The second step, if AF did not terminate, was PV isolation completion. The third step was linear lesion at the mitral isthmus and at the roof and at the CTI. And if there was no termination, we performed a DC shock. If there was termination to atrial tachycardia, we decided to recommend not to change the atrial tachycardia, but to perform a DC shock. We included 118 patients. The last patient has been included in July 2014. You see that the mean age was 64-year-old. Total AF history 40 months, uninterrupted AF duration of 4.4 months. Otherwise, you see LV ejection fraction 60, Schätzfast 2 score of 2. The LA diameter was 44, and median of 1 antiarrhythmic and 1 DC shock before the procedure. There were 40 patients who received during the history before the ablation amiodarone treatment. But we really tried to stop the amiodarone 2 months before the procedure to avoid some problems and to interpret the data. And so only 4 patients were on amio at the time of the procedure. For the rest, you see that 22% of the patients had a history of heart failure, 55% had hypertension, 6% had a history of stroke, and 8% had ischemic heart disease or dilated cardiomyopathy. The primary endpoint of the study was acute termination of atrial fibrillation to sinus rhythm or stable atrial tachycardia during ablation. These are the results. So first, with the first step only, driver ablation only, we had 78 of the 118 patients with AF termination with driver ablation only, which represents 64% of the patient. When we add PV completion and linear lesions, the 2 other steps, we reached 73% of atrial fibrillation termination. If you look at the global impact of of driver ablation on the AF process, so we define a significant AF cycle length prolongation of a prolongation of more than 10% of the baseline AF cycle length, and you see that only 6% of the patient didn't have any AF termination during driver ablation step and didn't have any AF cycle length prolongation. For the rest, 22% of the patient had no termination but had a significant AF cycle length prolongation. 47% of the patient had termination to atrial tachycardia, and 16% of the patient had termination directly to sinus rhythm during this driver ablation step. So we can say that in 94% of the patients, driver ablation had a significant impact on the AF process. This is the results depending on the centers. So you see that for the driver ablation here on the left, it resulted in AF termination from 36% for one center to 78% for another center. But basically, except for this center, all of the centers had at least 50% of AF termination. And for the global AF termination rate, you see that it comes from 55% to 86% of AF termination. Very importantly, none of these centers had any practical experience with the system before the study. Secondary endpoints are of duration to AF termination. These are the procedural characteristics. So you see that the time to AF termination was 44 minutes. The total RF time was 70 minutes. Total flow time was 30 minutes, and total procedural time was 211 minutes. Freedom from persistent AF at the end of the 12 months follow-up period, so we don't have the complete follow-up right now. I give you just a few thoughts about the methodology. So we had a 3 months blanking period. We asked to use the same antiarrhythmic drug as before the ablation if necessary. We recommend to stop the antiarrhythmic drug after 3 months if the patient didn't have any recurrence, and after 6 months otherwise. AF recurrence were considered as a failure, any AF recurrence of course. Any AF ablation was considered as a failure even during the blanking period. We had 24 hours Holter at 3 and 9 months, and more than 3 days Holter recordings at 6 and 12 months. Atrial tachycardia ablation was allowed during the follow-up, but only focused on the attack, so no additional substrate ablation. These are the results after a mean follow-up of 6 months. So you see that 83% of the patients were completely AF-free for this follow-up that we have right now. It's only preliminary results. Is there any difference between AF termination during the ablation process or not? You see 85% of the patients with AF termination were AF-free during the follow-up, and 77% of these patients were AF-free when there was no AF termination. Importantly, 72% of the patients are off drug now during this follow-up, so it's a very large amount of patients, I think. 31% of these patients had attack recurrence after the 3 months blocking period. And we had the redo ablation procedure for attack in 24 of these 36 patients. I can tell you right now that main attack were macro reentries in 60% of the case, mainly related to gap in linear lesions that had been performed during the first procedure, and also focal reentries in a minority of the case. In the majority of the case, these reentries were located at the same spatial location as the drivers during the initial procedures, but this has to be confirmed in the future. This is the actual follow-up, so you see that after 6 months, for instance, we have 72% of the patients off drug. We have already 106 patients. 75% of these patients were in sinus rhythm, 18% were in attack, and 7% were in atrial fibrillation. After the end of the 12 months follow-up, we have 35 patients right now, and it's more or less the same graph, taking into account that some of these patients have been reablated for attack. What about the reproducibility between centers? First, if you look down at the results here, concerning the termination with driver only, acute termination percentage, and freedom from AF at 6 months, you see that there is no significant difference, although you see that there is some difference between the centers. This was not significant. If you look at the RF time and the procedural time, there was some difference in between centers. You see centers with much lower rates, much lower RF time, and with much lower procedural time. As in Bordeaux, a very important point predicting AF termination during the ablation procedure was when the patient came into the lab in sinus rhythm. As you can see here, in this case, we had a very high rate of AF termination, while for the rest, we didn't have the same conclusion as in Bordeaux. We didn't see any difference concerning the duration of atrial fibrillation. It was more or less the same concerning the RF time to termination. When the patient was in sinus rhythm at the start of the procedure before induction, we could reach AF termination after only 30 minutes of RF time, while it was a little more when it was not the case. 21% of the patients had their RF time of less than 30 minutes to terminate. The other clinical predictors of AF termination were the number of driver regions. The more regions are involved with driver, the more difficult will be the procedure, and also the left atrial and the right atrial cycle lengths. What about the driver location? So you see that in 2/3 of the case, the drivers were located in the left atrium, and in the left atrium, the primary location were the veins, but this accounts for something like 30% of all of the driver locations. And you see that we could find driver otherwise everywhere else. And in 1/3 of the patient, in 1/3 of the case, the drivers were located into the right atrium almost everywhere, as you can see here. And this is more or less the same conclusion for the AF termination sites. You see that the veins were probably the sites where we had most of the termination in 30% of the cases, but in some of these patients where we had PV termination, of course, they received ablation at other sites before, so conclusions are a little bit difficult. But otherwise, you had termination at the right sites in 30% of the case, and it could be located everywhere. Give you an example of a typical electrophysiological procedure using the system. 77-year-old male. It was persistent history of 9 months, LA diameter of 4.5 centimeters. You see that the drivers were mainly located here on the septum, near the right veins, and on the inferior lay, and also on the right atrium. So we started with ablation of these drivers, and we were able to prolong the left atrial cycle length, but not the right atrial cycle length. And then ablation of this driver on the right side resulted to AF termination to atrial tachycardia. Last example about the importance of right atrial drivers. It's a 54-year-old female with persistent AF history of 3 months, and in this particular case, we had drivers only on the right atrium. He was a patient from Germany. So you see that we have 33 re-entries and 2 foci at the anterior right atrium, 1 re-entry and 10 foci at the CTI and CS os region, and then ablation only at the right side resulted at the spot resulted in AF termination directly to sinus rhythm. Last slide, is there any correlation between drivers and CAFE? So this has been studied by Isabel Deisenhofer with her patients in Munich, 15 patients only. But what was interesting to see is that when she analyzed the CAFE using the head-side system, she could see that it represents 50% of the bilateral surface, while the successful driver ablation accounted for about 19% of the bilateral surface area. Most of the driver, but not all, of the driver sites contain CAFE as defined by the system, and so that she concluded that the use of ECFU system seemed to result in a more specific selection of the CAFEs, leading to a more targeted ablation strategy. In conclusion, Mr. Chairman, ladies and gentlemen, ablation of AF drivers using the ECFU system is associated with a high rate of AF termination. Drivers are distributed in both atria, 1/3 in the right, 2/3 in the left. Results seem to be reproducible among centers without prior practical experience with the system, and preliminary chronic results seem to be promising. Thank you for your attention.
Thank you. We will take one question from Atul. He's been standing up for a long time. And then, if you can hold all your questions, because we will have a panel discussion after his question.
All right, so then I'll keep it quick because I'm going to sort of sneak 3 questions. First of all, very nice data. Why did you include linear ablation in this? Because that, to me, seems like it would contaminate the overall hypothesis and results of the study.
Yeah, we discussed about that, and actually we wanted to superimpose the methodology to the stepwise approach, mainly replacing the CAFE ablation by the ablation of the drivers, but putting this as a first step. But we wanted to compare maybe in the future stepwise approach with this approach.
And just to clarify, if the patient had a focal AT ablation, no substrate ablation, they were not counted as a failure?
If it was an ATAC, no, it was not a failure.
Okay. And finally, it's interesting that acute AF termination, you showed that if there was acute AF termination, the success rate was about 85%. No acute termination, the success rate was about 77%. So acute AF termination didn't seem to have the same discriminating value on long-term outcome as perhaps has been reported before.
Yeah, for the results that we have now with this limited follow-up, it's not significant, although we see some differences, not significant, but right.
All right, thank you very much.
Thank you.
Please.